Basak on the dais, please.
What were they? What progress have we made, if at all? And what continue to be our challenges? Advance nahi ho raha hai. Okay. If we look at the map of corneal blindness and the transplantation readiness, as it were, India is perhaps well equipped in both. We have the highest magnitude of color corneal blindness in the world. And we are also in some sense very ready to really tackle the problem by doing the required number of corneal transplants in our country. So the question always has been, how many do we have to do really to tackle the problem of corneal blindness in our country? The last year's performance, if you look at it, we performed between 25,000 to 30,000 transplants across the country. And our eye banks have harvested around 50,000 to 60,000 corneas. The need is, it is estimated that we need to perform around 100,000 corneal transplants a year to meet our demands. And that's just a guesstimate. We really don't have accurate numbers. We believe 100,000 will have significant impact. And to achieve that, we have to harvest 200,000 corneas approximately. When we consider what are the basic requisites for success of corneal transplantation, it's the quality of the donor cornea that we use, understanding of the recipient pathology, and to really understand more than where to do, where not to do a corneal transplant, even if there is a corneal opacity. And the third is a whole host of care issues, including the very important follow-up care. I think over the past 20 years, I think we have succeeded in putting a framework in place. We now know what a real eye bank means and the standards that are required for each eye bank. And we believe we have about 15, 20 of these really top-class eye banks, although the numbers suggest registered eye banks in hundreds. We have a cluster of cornea centers in our country, and many outside the cornea centers practicing corneal transplant surgery. We have education programs that train cornea specialists. And we also have models of delivery of cornea care. What I think today we need is optimal utilization of the corneas that are already available. There is always a concern that most eye banks, all the corneas harvested are not being used. That means significant scaling up of what we have to do. Regulations remain a hurdle for us. Despite all the limitations, we have made some progress. So the available corneas are about 50, 60,000. And when you apply that against active corneal transplant surgeons, this is the number that I got when I surveyed some of our cornea centers, the Eye Bank Association of India. We seem to have between 900 and 1,000 surgeons who perform corneal transplants in our country. But only 50 trained corneal surgeons, only 50% of them seem to do any kind of corneal transplant surgery. And from our own eye bank, the 270 or so that we distribute corneas to, only 20 seem to be very active. doing more than a critical number. So I believe the first step is to increase the optimal utilization. We need more surgeons to participate actively in corneal transplantation who are already trained and can perform corneal transplantation surgery very well. If we look at the future, we have to perhaps make sure every single ophthalmology residency program, of which there are hundreds in our country, should have an active corneal transplantation program, which they don't today. And every tertiary care hospital should also have an active corneal transplantation program, everyone having at least 1 to 2 well-trained cornea specialists in their faculty. And we also need many mentor institutions with comprehensive cornea programs. It's not just doing transplants. You need supportive services like refractive surgery, contact lens service, an eye bank that supplies high-quality corneas, the training and medical care of corneal diseases, microbiology and pathology support. Suppose we have 10 leading cornea centers, each doing 2,000 corneas a year, transplants a year. We reach about 20,000 with them. 200 medical colleges, if they do 200 each, 40,000. Another 200 independent corneal surgeons can contribute to another 40,000. And each of them also put in place a better follow-up system with their referring physicians and their networks. That will probably be the first step that we might consider. Because when you educate a person, you can change a life, but when you educate many, you can change the world. Cornea specialists and ophthalmologists in practice both need to be involved to make these services available, accessible, and affordable, enabling care with a greater reach. This quote is more applicable in the area of corneal transplantation than perhaps any other area of medicine. Medicine is a life of responsibility. Thank you.
Thank you, sir. I now request Professor Jeevan Tityal, sir, to present his talk on DSEC, Practice, Precision and Perfection.
Thank you so much, Dr. Manpreet and Professor Rao, Dr. Basak, and very senior colleagues sitting in this audience. We all have a responsibility to train people, to make things available for corneal surgeons, and do a proper assessment of the country to know what is the load of people requiring corneal transplant surgeries. Many people are working, many institutions are working in this direction. I strongly feel we require, as Dr. Rao said, we require a very, very comprehensive way of looking into this to really get things done. I'm pretty sure if we work together, Cornea Society India and the other people, we can achieve this in very, very effective manner also. But my part today is talk about something on surgery, that is DSEC, decimal scoring automated endothelial keratoplasty, and look for a PPP and practice, precisely do, and perfection to achieve this, to have something. If you look into indication of endothelial keratoplasty in our area, there are various situations where corneal endothelium may not be functional as we desire. But there are situations where surgery can be difficult and challenging because you have options now, DSEC, DMEC, PDEC, and many other ways to do these procedures also. But these are conditions where I feel strongly DMEC may not be a very suitable option, where DSEC still is a suitable option for these cases of difficult scenario also. The first important thing as far as donor fashion is concerned is very important, sizing of donor, and the thickness of tissue also very important. We talk about thin tissue, that is maybe ultra thin, nano thin tissue, which can be achieved by something like doing a proper assessment of our donor thickness, selecting the proper microkeratome head, so that you achieve around 100 micron corneal thickness, stromal thickness with the endothelial complex being there. Thinner the tissue, better is going to be outcome for a patient in terms of optical wise, because thin tissue will get lesser addition of tissue, lesser higher order aberration induction in these cases, and outcome may be better. And uniformity of tissue is also very, very important, all around center to periphery, which we nicely achieve with automated keratome manufacturing the DSEC lenticule. We understand in this section you'll have a slightly thicker peripheral tissue. Normally we cut 10 millimeter size, and once you trephine 7.5 or 8 millimeter, the peripheral thick tissue is avoided. And this is how you fashion a tissue very nicely for DSEC patient also. The surgery is quite simple. Once you have fashioned out this tissue, this is a similar way we have fashioned out around 100 micron tissue have been taken out. Once do a proper scoring of a patient, normally I use pull-in technique for all my cases. Vucin glide being used here with the preservative medium over that. You can use various techniques. You can have a push-in technique, you have a pull-in technique, you have injected techniques. All techniques work well in your hands, so make sure you do a perfect job. I'll hold the tissue outside the area, then take entire glide towards the wound area so that nothing rubs against the tissue there, and pull the tissue under a low pressurized anterior chamber. You can see here, despite that, the graft site is not opened yet correctly, and once you inject a little fluid here, the graft will open up. And the advantage of intra-op OCT is really there in all lamellar procedures, if not in all corneal procedures. Once you tamponade the graft for some time, it gets attached. Classically, we didn't know how much time it requires for a graft to get attached. And subsequently, we did a study to compare how much time it will require if you do a manipulation, no manipulation in these cases, as AIOCT guided. We realized once you pressurize the anterior chamber and do a massage from anterior side, the graft gets attached within a minute. And you should wait for another 3 to 5 minutes. That's sufficient time for a graft to get attached in normal situations. And that is what we realized. Don't have to keep a pressure for a 10-15 minutes, which may be sometime compromising for your patient, especially glaucomatous patient, which is normally seen in these cases also. You all know orientation of graft can be judged by a double ring sign, or you have a bevel, acute bevel sign, which can be seen in the OCT microscope. You can see next day anti-subsequent OCT also. That gives you a nice way to look into it. So DSEC surgery is simple, effective if done in a proper manner. You can do in a various other modified way also. This is the technique we described for our post-vitrectomy eyes, where we could implant the lens, secondary implantation, and giving a little pars plana infusion gives a pressurized anterior chamber and posterior chamber. The chances of graft dislocation is minimized. You can do secondary implantation, which may be a scleral fixation, maybe a sulcus implantation. Then subsequently, you can inject a graft also. And this graft floats very nicely because you have a fluid from a posterior chamber, and there's hardly any chance for air bubble going back behind the pupillary plane, which is a major difficulty in aphakic eyes. So these simple techniques really improvises your outcome in these patients also. This is one situation we keep facing, the antichamber IOL and pseudophakic bullous keratopathy. If it is nicely fixed, you can still do a DSEC without removing the nicely fit AC IOL and having a deep chamber without distorted angle anatomy in these cases also. This is one of our cases doing so well after the surgery, and the surgical technique is slightly, maybe little challenging sometimes, especially the bubble going behind the IOL, and things can be tough also. This DSEC surgery can be translated to other difficult areas like a pediatric cases, where you may have a difficulty doing DMEC sometimes because visibility may be poor. But now we have also started doing DMEC in these patients because space is less in these cases because it's a phakic surgery. And in all cases of pseudophakic bullous keratopathy or phakic cases, I do my incision from nasal side and end towards the, open this towards the end of surgery so that this becomes absolutely virgin incision, doesn't require suturing also. So nice scoring can be done in these patients. I normally don't like to use trypan blue in these cases because I don't know what will be the effect of trypan blue in the normal healthy lens epithelial cells in these cases. Now, if you have poor visibility, you might use, but this is a very nice way to scroll the entire DMEC desmet complex, which is very difficult to be taken out sometimes. If you have this reverse spatula, it can really give you a nice scoring happening in these patients. And surgery is simpler like we do in other patients. Make sure you have incision little temporal to the central area so they don't damage the pupillary area where the lens may be open. And under the guidance of AIOC2024 microscope, you can see a nice attachment. This is what you see in these cases, clarity after 6 months. Integrated microscope does give you a lot of advantage of doing a lamellar procedure, includes DSEC also. In TAS, we realize you have to wait for inflammation to settle down because there is a challenge of repeat inflammation, glaucoma in these patients. If you wait for 3 to 6 months, the outcomes are reasonably good in these patients. This is a classical post-op result of cases where you have a pigmentation, necklace type of pigmentation around the DSEC graft in these cases. To summarize, DSEC is simpler surgery, easy to learn and easy to make perfection. The practice makes your surgical skill improve. Precision will give you a better predictable result after these surgeries, and perfection gives you a better outcome for your patient in terms of improving success and the quality of your patient. I would consider younger people sitting here, you should also learn DSEC along with the DMEC procedure for future of our patients. Thank you for your kind listening.
Thank you, sir. We now move on to the next talk, DMEC in complex situations by Dr. Rajesh Vogla.
To DSEC, we move on to performing DMEC in complex situations. I have no financial interest to disclose. Now, the insertion of the DMEC donor is usually commonly performed using a flushing technique, where using a glass or a plastic injector, you flush the donor into the eye. And if the anterior chamber volume is not sufficient, sometimes by the time you get the donor into the eye, the chamber is pressurized and the donor scroll has a tendency to kind of jump out of the eye. So you can have a partial or total expulsion. So to overcome that, we devised a technique where we use an AC maintainer. And the other thing was to achieve the double scroll configuration, you can agitate the fluid within the glass column to get a single scroll go into a double scroll configuration. And this we could achieve 80% of the time. And this helps in the unfolding of the donor scroll. Here you can see with the AC maintainer being on, the tip is inserted into the eye, then the AC maintainer is switched off and disconnected from the IV tubing. Now when you inject the donor, you have a unidirectional flow. There is no counter pressure. The chamber also shallow, so configuration of the DMEC scroll is maintained. So the double scroll orientation is well maintained, and then the unfolding is pretty atraumatic. And using this principle in complex scenarios makes performing a DMEC surgery quite simple. This is just to again show you what we are doing. We have the AC maintainer connected. The tip of the injector goes into the eye, AC maintainer is switched off, and then we disconnect from the IV tubing. Now when you push the donor into the eye, you find that there is no counter pressure. The donor just goes into the eye, and there is no tendency for the donor scroll to rush out of the eye when you withdraw the tip of your cartridge from the eye. So that again gives a big advantage, and your orientation of the scroll is also maintained. The other thing that I realized is sometimes putting an air bubble under the donor scroll, once you have unfolded the donor scroll, is a challenge, because if you get an uncontrolled insertion of the air bubble can displace the well-centered DMEC scroll that you have opened up. So we use this back flush cannula, what the retina surgeons use. Here you have a silicone tubing. When you press on the tubing, you get a very small air bubble that comes out of the tip. So we use that for marking our donor as well. You can see that when the donor is being prepared. So thereby here we don't create that 3 millimeter stromal window. We mark it over the air bubble, and this is quite useful. Like inside the eye, you can see that's the DMEC scroll unfolded, and we can very easily put a small air bubble to lift up the graft and without the fear of displacing. So these are again two principles that we use in complex scenarios. In shallow anterior chamber that you get in pediatric eyes with ACIOL, with disorganized AC peripheral synechiae, if you get your donor graft in the upside orientation, sometimes flipping that over can be quite a challenge. So I think it's important, like in this case of CHED, we use the same principle of using the AC maintainer, and we make sure that the tip of the cartridge goes across the pupils, because you don't want to damage the crystalline lens, and then you get your donor scroll into the eye. Secure the wound, and as you tap, you will find that because the donor is in the right orientation, you can very easily get the scroll to open up and just put an air bubble to complete the surgery. That's the same patient in the post-op period. You can see that the cornea has cleared up quite well, and it's a great procedure to perform in eyes with shed where the cornea is already very thick, so you don't want to add volume of a DSEC graft to the shed cornea. In complex scenarios, the other way of insertion is the endo-in technique, where you trifold the donor with the endothelium on the inner side, pretty much like a DSEC graft. This is then loaded onto a IOL cartridge. This was quite well described by Professor Busin, and Donald do it with the endoglide as well, the endo-in technique. And once you put it into the IOL cartridge, the cartridge is blocked from the posterior direction. Then keeping an AC maintainer running slow flow, you can pull the graft endo-in and don't let go of the graft. You tap on the surface to open up, and then you put a small air bubble in between which lifts up the scroll, and then you can manipulate and open up the scroll. So this is done in an eye with the presence of a AC IOL, and you can see that without displacing the IOL or exchanging it, you can still perform a DMEC surgery quite well. This is again a patient, one-eyed patient, has multiple glaucoma surgeries, has a failed cornea. So here to do the surgery, we go ahead, there's hardly any working space. So we did the synucleolysis first, and once we did the synucleolysis, before we go ahead, we try to put a test air bubble, and we find that it's very difficult to retain an air bubble because of the excessive small eye. So we go ahead and do a limited anterior vitrectomy. Once you do that limited anterior vitrectomy, we get more space in the anterior chamber, and now you see that when I put an air bubble in the anterior chamber, I'm able to retain the chamber very well. So this has to be decided beforehand. Once you prepare your donor and get the donor into the eye, and then you're struggling to keep an air bubble into the eye, it can be very challenging, especially in these eyes. So we were able to do that, and if you have a long tube, you need to trim that. We use the endo-in, the pull-through technique even for this eye. Sometimes you need to reduce the size of the donor, and you can have a good outcome. You can see post-operatively the patient did very well. In a vitrectomized eye or a very deep anterior chamber, unfolding is a problem. Here you can see that we put an air bubble within the scroll, and then we use the air bubble as an instrument to help unfold the graft. Otherwise, in a chamber that does not shallow, unfolding can be quite challenging as well. Intraoperative bleeding is definitely a concern. Commonly it can happen from your main wound, from your side port, or sometimes even from the inferior PI. So you can see that in this case, as we were manipulating to open up the donor scroll, the inferior PI, where the bleeding had actually had stopped after the PI was made, but the tapping process again dislodged, and we started having bleeding. And in this scenario, trying to unfold the graft, control the bleeding, it can become very difficult. And the longer you manipulate, the stain of the donor graft goes away, and then, in this case, finally we had to give it up and come back and repeat the surgery, and that was the outcome for that case, which did very well. Here we again are doing a case where we had a deep chamber, a soft eye, where we put an air bubble, unfolded the graft, put an air bubble, and then we found, and that's the light pipe being used to look at the orientation, and we found that maybe in one quadrant there is some peripheral synechiae. We went to release it, and then we induced bleeding. So, sometimes you have to, you need to know when to stop. Didn't want to leave the blood inside, so I kept a mid-size air bubble in the AC, went with the Simcoe and gently washed out that blood, and then put in an air bubble and completed the surgery. But again, this is again a difficult scenario, because while you're going and washing, sometimes you can catch the donor and you can displace. A light pipe is very useful to look at the position, the final position of the graft as well. If you have eye pseudophakic bullous keratopathy where there is a large pre-existing YAG capsulotomy, and if you go ahead and do your DMEC surgery, the problem can be, there may not be any vitreous in the anterior chamber when you start the surgery, but when you shallow the chamber and the eye is soft, and if you have a large capsulotomy, a YAG capsulotomy, you can have vitreous that herniates to the front. So performing a vitrectomy in this scenario is also very difficult once you have your scroll in the anterior chamber. So we did we used pilocarpine to constrict the pupil, did a dry Wexel excision of the vitreous, and then we, with minimal manipulation, opened up the graft. Again, we find peaking of the pupil. Again, we had to do a little bit of sponge excision of the vitreous, and finally we managed to open up the graft and completed the surgery. That's the post-op appearance of the same. This is again maybe the last video. In this kind of scenario where you have a complex anterior segment, failed DSEC graft, you open up and you put in your donor scroll, and you're trying to open up, because it's a deep chamber, vitrectomized eye, the scroll is not opening, and the more you manipulate, sometimes the scroll tends to go the reverse direction. To prevent that from happening, you can even use micro forceps to go and hold one edge of the graft to stabilize it, and then tap to open up the scroll so that the orientation is maintained and you don't lose the orientation. And then at the end of it, once it's opened up, we put an air bubble and complete the surgery. Pupilloplasty can also be performed, and we mentioned about the light pipe orientation. So here you can see that we have a hazy cornea. We put in the graph, but just for confirmation, you can use a light pipe to see that your F or the S stamp, and that gives you a peaceful night's sleep so that you know that you have put in your graft the right way. This is again another scenario where you can use the light pipe. We have opened up the scroll, but once you put your final big, large bubble, you can always put the light pipe to identify the orientation in hazy cornea, and then put in the final bubble to complete the surgery. You can do it in complex scenarios like ice syndrome. So basically, sometimes you need a modified approach. For very shallow chamber, you may need an anterior vitrectomy to improve the working space. Pull-through technique, if you don't use it routinely, in these kind of scenarios, they are quite useful. And the other alternative maybe would be to do an ultra-thin DSEC in those complex scenarios. Thank you. Thank you for your patient hearing.
Thank you, sir. A really wonderful collection of cases. I now invite Dr. Samar Basak to present his talk on DVEC after 5 years.
So, and this is without keratoplasty procedure. So, we call it Descemet stripping without endothelial keratoplasty. I'll be showing some of my initial cases and my thoughts about this procedure. It is also called DSO. So, Fuchs dystrophy, the treatment is from medicine to surgery to cell therapy. If you see that 55% at DSEC, 36% DMEC, and many people across the world also do PK in these cases. But the pathogenesis still remains unclear even after 110 years. So this is just the routine procedure in one eye DSEC and other eye DMEC, and the results are gratifying, and we know that. And the results after say 11 years or 8 years, the endothelial cell counts are also looking so good that you always enjoy this kind of surgery. So this technique was described almost 8-9 years back. So can we go without, especially with Fuchs dystrophy and center? There are several reports in the literature, and it works some of the cases of Fuchs dystrophy. So this type of case is very important, central type of Fuchs dystrophy, so you need to see and select the case very nicely. There are several case reports. In some hands it works nicely, some it didn't work well, and failure rate is almost 100% in some of the cases. So how does it work? Nobody actually knows, but normally it is feels that DMEC, when we do a DM defect, so cell migration happens and it covers the area, so that it is I have done only 5 cases. One of the patient actually lost after my procedure and never come back. So I'll be showing the 4 on a timeline basis. The patient selection, as I said, very important: central Fuchs dystrophy, focal central edema, clear periphery. The peripheral count must be more than 1500, and the patient symptom is intolerable glare, reduction of visual acuity. It may be phakic or pseudophakic, may be combined with phacosurgery. Otherwise, he or she will be a very good candidate for future DMEC. So this is the case. You see in the left-hand side photograph the central image of the two specular, and in the left eye I have already done DMEC, and this patient, this eye is doing. When I took the right eye, I took several other photographs from peripheral area, paracentral zone, and if you see this kind of cells in the paracentral area, so you can choose this patient. So surgery is very simple, and you see that it takes only maybe 1 or 2 minutes. So after doing phaco, you just give a marking of 4 millimeter zone, use your reverse Sinski hook to make a line, and then use that Rexis either you can use only steroid in this. So for few days only, no need of steroid for a longer period of time. So this is my first patient. Right eye DMAC done, left eye. So this is pseudophakic corneal edema. You see that day 1, it is ugly look, but at 1 month the look is very good. ASOCT also showing very good progression. Cell count, okay, it is good, but this is after 3 months. You see the retro, the clear area is visible. And this is after 4 years. In between COVID happens, and this some of the patient lost, but there is no question of steroid in this patient. So this patient, in the right eye, you see that 3rd year, the patient right eye doing good, that is DMAC done, but left eye, the cell is such a big cells in the center. But 4 years, he developed edema. Then I had to go to DMAC, and this DMAC last right lower 4 pictures actually after 6 months of doing DMAC, and this patient is doing good after DMAC. This is my first patient. This is my second patient, again central Fuchs. You see the clear central edema. And so one eye I did DMAC in 17, and I took phaco with DUAC. And if you see the chronological appearance of the cornea, day 1, day 7, month 1, month 2, month 6, month 9, the cornea is getting clearer and clearer, and the patient is very happy because she has not to put any drops in that eye. Then this is the right eye, the left eye, again after 1 year, the pachy in the both eyes are same, 6/6 vision in both the eyes. And if you see the retro, the things are going good. This is the typical desmotor axis area. But after 15 months, she started developing edema, and you could see that pachy was 584. And I started, I borrowed from Japan, and this rho kinase inhibition given her for 2 months. And by 3 months, this cornea edema goes, and the pachy was 532. But this is the cell count, and probably you will not like the cell appearance in the left eye of the patient. So this patient, after 2.5 years, again developed corneal edema, and I need to go for DMAC procedure. This is the 3rd DUAC, 18 phaco with DUAC, and this patient never cleared within 3 months. So he was sitting on my head and do something, and I did DMAC in this patient. This is my 4th DUAC, and again, one eye DMAC, another eye DUAC, in this case right eye. And if you see that rhexis was not that regular patient, it was done under topical, and patient was there is little irregular. And if you see the ASOCT, there is a distinct gap in the central part of the DM. And this patient, after 5 years, 5.6 years, and other eye is DMAC. So after 5.5 years, the cornea is good, vision 6/6, but the cell line is not doing good. So outcomes, one patient lost, I said that, but only one patient is doing fine after 5 years. And probably that will also go after maybe 6 months or 1 year or so. One interesting findings, if you see the picture of 6 months and 12 months retroillumination, there is reappearance of guttata in this central area where I have done desmetorexis. This is the other patient, so guttata is appearing in the center, where I have removed the whole DM endothelial complex. And if you see, this is the distinctly, you can see that central area, after 18 months, the guttata appearance in the retroillumination. This is also the last patient, 4th DA. This patient was going good, but you could see that there are certain holes and other things are appearing. So if you see the ASOCT picture in the central part, there is appearance of something elevated area. this patient is actually doing good, and you see that central part only the monolayer is there of endothelium. So if you see my previous one, this is good. So you always like this kind of picture, but after 1.5 months to 2 years, or 1.5 years to 2 years, you do not like this kind of cell. Compared to I showed you earlier, down the line 11 years or 8 years, your DSEC or DMEC, your patients are doing good. So there are certain reports of long-term results, there are certain reports of recurrence of gutata and endothelial dysfunction after successful DSO only. And so FECD, if you consider the pathogenesis, so it is actually the chicken or egg formula kind of thing, whether it is a DM disease or it is a endothelial disease. Still, there are some questions. There are also some a question about peripheral mature kind of cells. Those are actually contributing towards that. So at this point, basic question comes to mind: what is the pathogenesis of Fuchs? Is it a DM disease or endothelial disease? What actually gutata are? Excrescence of DM or deposition of RER or other substance, a diseased endothelium? Because if you see the genesis, the genetic factor and environment factor both plays in case of FECD. So DVEC, is it really helpful in Fuchs? Probably no. Possibly it can delay the DMEC procedure for 1 to 5 years. Thank you very much for your patience hearing.
Thank you, Samar. The next speaker is Dr. Muralidhar Ramappa. Murali is the head of Cornea Center in the Hyderabad campus of L.V. Prasada Institute. He'll speak to us on limbokeratoplasty in sclerocornea.
Yeah, thank you, Dr. Rao. A very good afternoon. So I'll be speaking, limbokeratoplasty, meaning we are using a donor tissue limbus along with the corneal transplantation. So we are basically repurposing this technique for a sclerocornea. Do not have any relevant financial disclosure. As we all know, sclerocornea is one of the very rare, severe form of an anterior segment abnormality, wherein you have a dense corneal opacification, extensive vascularization, ill-defined limbus with a poor limbal analgae. All are high risk factor for a corneal transplantation. And cases which have a peripheral corneoscleral adhesion, that is an independent risk factor for not only for a glaucoma and also graft failure. Therefore, we have to have an alternative to the penetrating keratoplasty. This is a phenotypic description of a typical sclerocornea. You have ill-defined limbus, anteriorly inserted conjunctiva. Such a conjunctiva not only makes surface is a pore and also brings in lot of blood vessel into the cornea. You could see here ill-defined limbus. When we measured limbal analgae in these cases, they were extremely deficient. It's also important to perform a UBM in such cases to pick up extensive peripheral iridocorneal adhesion. These are one of the biggest risk factor for a graft failure. This has to be distinguished from the peripheral sclerocornea, where central cornea is relatively clear. You do have a ill-defined limbus, and if you look at the entire limbal analgae is stretched. Not only they are poor, and also they are anteriorly inserted. In this particular instance, we don't have to perform any transplantation. All they need is a refractive correction. Again, a slit view showing a discoid shape configuration with the center being more thicker than the periphery. So the histopathology again shows an abnormal thickened epithelium, and there are debate whether they belongs to cornea or conjunctiva. Bowman's membrane is entirely destroyed, and these fibers not only irregular and thick, they are almost reminiscent of a sclera. And as I said, an entire pancorneal vascularization, both from episcleral as well as a conjunctival. And in these cases, desmet is found to be rudimentary or completely absent. In addition, you have a iridocorneal adhesions All these factors makes, the corneal transplantation abysmally poor. As Dr. Rao was alluding, there are cases we need to know when not to do corneal transplantation. I think this has been largely practiced. The sclerocornea means we were never, doing any transplantation in such cases. Why do they have such kind of an abnormal? We did even immunophenotyping in these cases. Although all stromal elements natively belongs to cornea, they have an additional sulfated keratin sulfate within the extracellular matrix that makes, these collagen fibers are wavy, irregular, that lead to loss in a transparency. And this subset of cases can also have a poor limbal analgae that lead to the primary stem cell deficiency. This particular work I pursued when I was with Ken Nischel. So this particular video you are showing a normal architecture of the limbal analgae, what we call it as a palisade. And in a patients with the sclerocornea, they have a extremely poor palisades. To maintain the normal corneal homeostasis, we need to have a 5 to 6 limbal palisades for every square millimeter. That helps in maintaining the corneal epithelial milieu postoperatively. With this background, this is one of the cases to show congenital aniridia having a primary congenital deficiency. These cases, if we embark on a corneal transplantation, 100% they fail. So why do we have a sclerocornea? As I said, it's basically developmental abnormality, which one of these transcription factor primarily regulate the primordial cells, which in turn, work on a neural crest cells in a downstream pathway. Because if there is a failure in a migration of the neural crest cells between 6 to 8 weeks, that lead to the what you call as a typical sclerocornea. And published literatures have shown within first year, nearly 70% of these grafts fail. So with this background, we wanted to actually address not only the central corneal visual axis and also limbus. So this is one of the index case where showing ill-defined limbus, poor limbal analgae. And in the left eye, we can actually see a sliver of a limbus with the limbal pigmentation. This is a surgical video, a very classic case of a sclerocornea. We need to ensure and respect the anatomical landmark. We are not only preserving the recipient's limbal stem cells, although which are abnormal, and we are also supplementing donor limbal stem cells. Thankfully, we have an access to high quality donor tissue, as Dr. Rao was mentioning. And these donors should be very young, less than 30, with a DPT of less than 6 hours. At least a 1 quadrant of a limbus, healthy limbus. I generally always superior limbus that is well protected under the upper lid, oriented. Rest of the steps are similar to any transplantation. Post-operatively, I also supplement them with a specialized contact lens. And in one of the the child had lost the contact lens. You can see a florid inflammation with all loosened suture. Meaning, this contact lens, like similar to the keratoprosthesis, if we continue for a long time until all sutures are out, it actually minimizes the surface inflammation and also prevent the irreversible rejection. This particular child doing extremely well with this 5 to 6 millimeter graft, and there are numerous such examples. In interest of the time, so mostly, the children were between 3 to 4 months. Most of them have a total sclerocornea, and most complications were seen in the first 6 months to 12 months. And nearly 90% of the rejection end up having a failure in such cases. In comparison to the literature, at the end of first year, we had a graft survival 68%, second year 58%, and nearly 50% of them had during neuroplasticity within that 3-year time frame. Even if the graft fails, you have a window of opportunity to revisit such cases. So one of the index case has completed 5 years with a good specular, doing exceedingly well. To conclude, children with a significant total corneal opacification due to sclerocornea can help not only achieve a good anatomical outcome, so is a functional outcome. And some of the measures, both topical and a systemic immunomodulator, are key. There was a concept, Dr. Rao would agree with me, in late 70s and 60s, there is an immune privilege within that critical time frame before even the lymphoid, that is the cellular system, sets in. If we can identify that critical period, so we can actually evade the risk of rejection. And this definitely ensure achieving a long-term outcome in this rare and difficult cases. Thank you for your kind attention.
Our next speaker is Professor Jodh Mehta, a successful long-term transplantation from India to Singapore. Head of Singapore National Eye Center and one of the most distinguished cornea specialists around the world.
Thank you. Okay, great. So good afternoon. So I'm extremely privileged to be presenting in this great session. So I'm going to be talking about something slightly different with respect to endothelial keratoplasty, and I'll show you why we do this surgical procedure. So it's called femtosecond assisted DMAC or FAD. So these are my disclosures. So of course all of you will know the Mehta surgery has really become the gold standard procedure for choice for corneal transplantation, whether this is respecting to changing the endothelium in the form of EK, DMAC or DSEC, or stromal disease, where it's one of the ALK techniques. But you know, we still need to do penetrating keratoplasty. Only about 14% of my cases are penetrating keratoplasties these days. And sometimes it can be quite difficult to determine which is the correct kind of procedure to do, especially if you do a lot of EK surgery. So I'll show you this case to start with. 70-year-old Chinese lady. So Professor Rao, most of my patients are Chinese. 72-year-old, right eye reduced visual acuity from herpes simplex with a recurrence. Right eye pseudophakic, and you can see the herpes simplex virus on the stroma. Basically, it increased and started affecting her vision. She was on oral prophylaxis, and her vision had dropped basically to count fingers. If you look at her ASOCT, you can see there's a deep stromal scar, which you can see obviously on the slit lamp, and she has peripheral vascularization, so we know there's a high risk of penetrating keratoplasty, and it's herpes simplex as well. So of course, even higher risk of doing a full thickness PK as well. And I felt that there was enough room there to do basically a good dog surgery. But if you look a little bit more closely on the ASOCT, you'll see these little ridges there on the endothelium. And this really is something to be careful of when you're doing herpes simplex cases, because this is actually a fold in Descemet's membrane. I'll show you this, how it can have an effect directly on the surgery. So we went ahead first with a manual dissection technique to basically do the dog surgery. So this is the standard way we will normally do dog if we're not going to go basically to get a big bubble in these small high-risk cases. So the idea is to do a deep manual dissection as deep as possible. And you can see with the surgery, and I'll show you the result on the right-hand side as we get deeper, you'll see that as I got deeper down to within 50 microns of Descemet's membrane, you can see I saw these ridges and folds in Descemet's. And typically you do see this with herpes simplex virus sometimes, where you get this ridging basically on the Descemet's. And this is a complete fold in the stroma. And there'll be some defunctive endothelial cells as well there. If you look at this in a little bit more detail, you can see it on the slit lamp, and this is the post-operative AIOC2024. Her vision improved from count fingers up to 645. You can see the folds now coming on the video as I'm getting closer with the dissection. You do have to be careful. You can easily rupture these folds when you're doing the surgery as well. So we were left with the decision basically of either leaving it. She was 645. She had minimal improvement with the rigid gas pulmonary contact lens. Some people said, well, you could do a DMAC, which I'll show you why you can't do a DMAC, or of course you could do a PK, but then of course you'd had to undergone 2 surgeries. So the reason why you can't do a DMAC in this situation is that if you look at basically the OCT in a bit more detail over here post-op, what you'll see is that you'll see the Descemet's membrane, and if you just do a DMAC, all you're going to be doing is removing the Descemet's membrane and leaving that stromal scarring behind. So what you want to do is basically do a femto-assisted DMAC, and the way we basically do is that we cut the inside, from the inside of the anterior chamber, into the stromal tissue using a femtosecond laser. And for the lasers to do this, I use the liquid penetrating keratoplasty module on the Z8 femtosecond laser. So this is the surgery. So basically after it's basically marked, you dock with a liquid applanating system on the Z8 femtosecond laser. This allows you to basically cut from the posterior surface, and you can individualize and set your cut 30 degrees all the way around the graft, so you know exactly how high you're cutting up from the posterior side into basically the stromal tissue. So it's truly real-time adjustment of the vertical cut. You then simply basically fire the femtosecond laser once you've basically gone round on the OCT. So you can check every 30 degrees round, so you're ready, then you fire the laser, so it's firing from the posterior side upwards, and you can vary the height and customize it depending on how you basically want. So you can see the bubbles where the laser's been fired, then you go around with the Sinskey hook and you simply basically just detach the area of where the laser is cut. Now of course where there's stitches left behind, you find a little bit of adhesion, sometimes you have to lose a little bit of a forceps, and once you remove the tissue from the inside area, you're going to basically replace this, and typically the way I replace this now is you can see the tissue over there with the scarred area has basically been removed, and typically I replace this with the standard DMAC tissue, and of course I do an endo-in technique, and you have much more control on the graft, and of course the tricky thing here is you need to fit the graft into that area that you've created with the femtosecond laser in 3 dimensions. So you do need to have good control of the graft to adjust it directly into position itself. So you can see the adjustments over here. And once I'm happy with the position, with the forceps, then simply I'll put a bubble inside the anterior chamber, there we go, and then basically the rest of the surgery is normal, where your tamponade basically is normal. So this is the first case I actually did, day 1 post-op. You can see a small, basically, detachment inferiorly. We went back and rebubbled her with SO6, and basically got a good improvement in visual acuity outcomes. So she went from 645 to 69 with a pretty good cell count basically at 1 year. This is the second case, a case that was done by a colleague of mine who basically had previous fungal keratitis with a scar. They did basically a dog procedure, then somebody did a cataract surgery after this. This was during COVID. Vision got up at 624, and then they were sent to me a year later afterwards with a reduction in visual acuity. So I went back and did the same procedure as I showed you on the previous case, and the patient got a pretty good outcome with respect to visual acuity, as also basically a cell count as well. So I'll show you a slightly more complicated case now. This is a 7-year-old girl with a diagnosis of pediatric blepharokeratitis related to Demodex. She was on usual topical therapy, and she was having recurrent flares of her PBK. We lost her to follow-up for almost basically 3 or 4 years. She then represented 3 years later with a reduction of visual acuity in the right eye. You can see that central basically scarring with basically thinning. She then disappeared again. She was seen in private clinic for about 2 years. Her vision had dropped basically to count fingers, and she came to my clinic like this with a hole basically in her eye where she perforated over the area of basically thinning. So I did a manual basically dog for her, and you'll see there was a little bit of basically a desmoid rupture basically during the surgery. So I rebubbled and repaired basically the dog. As it basically settled down, we took out the stitches. She got to basically about 636. And again, we lost her to follow-up for 2 years, and she pitched up back to my clinic looking like she did on the right-hand side. So again, you'll see the deep central scarring on the surface there. So I took her back, and then I did a repeat dog for her at that time. This is what she was like at day 1 post-op. You'll see why on the video where the central perforation basically opened. Then I went back to basically seal that again. And this is basically how she ended up, about 636. But you can see that scarring basically on the posterior side. So the plan was then for her to undergo a repeat femto-DMAC procedure after we basically stabilized the ocular surface. And I'll show you this when you're doing repeat dogs. Of course, in previous perforation eyes, they can be quite challenging, especially if they've got a large hole over here itself. But these are still doable, and it's still worthwhile doing a dog in this situation as opposed to doing a penetrating keratoplasty, especially in such a young child. So as we repeated the central area, you'll see why there was basically a double anterior chamber on day 1. So as I basically peel off with the old scar, you can see the leak from over there, and you'll see a hole basically where I tried to seal this afterwards. And generally, you can basically be able to tamponade this to get this to seal. So we went back to do a repeat, basically femto dog for her. So this is the surgery. So she's phakic, of course. She's only, I think, 15 now. So went back. Surgery's exactly the same. So again, you peel away basically the area that's been cut. The bubbles will tell you where the margin of the laser basically cut is around the surface, and you're using a reverse Sinskey and a pair of forceps, you can gently peel away the separation. Sometimes if the margin between the graft host junction and the femto cut is very close, you can get some separation there, like you can see that in the top part over here itself. So I'll push away that area there to keep that away and keep it intact. So once the graft is basically out, so this is basically then ready to go. Obviously where there's area of haze, if the laser doesn't cut, as well as the area where it's basically clear. And then we basically will put the DMAC in. So this is DMAC in a phakic situation in the standard same way. And the advantage of using an endo-in procedure is that you don't have to worry basically about channeling the anterior chamber. So the graft basically will come in the standard way. and then this is basically opened up, and like I said, you've got to try to get it within that gap there that you've created basically within the femtosecond laser. So in the interest of time, I'll just show you the outcome. So this is her basically 2017. This is after her basically second dog. Down below over here, so the first dog, and then basically the second dog, and this is how she is now, basically 4 years, basically post-op. So pretty good outcome for her. So conclusion, with an increasing trend to perform lamellar surgery, sometimes it's difficult to ascertain endothelial damage in stromal scars, especially if they're very, very posterior. And following dog, even though there's an improvement, you can get residual folds that limit the oral visual acuity. The ZA intraoperative OCT guided femtosecond laser allows customized depth of this vertical trifine. This is using the liquid applanator, so you don't get any distortion on the corneal surface like you see with the flap applanator where you get those posterior folds. This allows you to do an accurate, basically vertical cut. The challenge is slightly, obviously, placing the DMEC basically in the gap, but you can see from the results in our paper you see very soon, you can get good functional recovery achievable with using this procedure. Thank you for your attention.
Thank you, Jodhbir. The final speaker is Dr. Amar Agarwal, Chair and Founder of Agarwal Hospitals, and an outstanding surgeon and an entrepreneur par excellence.
On karo. Lagao.
As you can see, even the head table, there is a very high attrition rate.
Thank you very much, Professor Rao. So let's look at this PDEC technique which we started, and the basic advantage is we published this in the British Journal of Ophthalmology with Harminder Dua. Basic idea is looking at the endothelium. I'm creating a bubble. That's a type 1 bubble, as it doesn't go to the periphery. I make a knife incision, inject trypan blue, and cut that. Now you see, this is the 9-month donor. That's a 1-year donor. In DSEC, you are having stroma. In DMEC, you just have the endothelium and desmase. In PDEC, you have with that the Dua's layer. The advantage of that comes is I use only young donors. So we don't go above 35 to 40. That's the big advantage in the PDEC. The second thing is the Dua's layer, what it does is it splints the tissue. So I can manipulate it very easily. Compartmentalizing the eye is another important step in these extreme surgeries when we are doing. Because suppose you don't manage the iris repair or the IOL subluxation, you will be in trouble. Because that air is going to go behind. And when the air goes behind, the graft will detach. So always remember, before we move into the PDEC technique, we will repair that IOL if it is subluxed. We will fix the iris repair always, because a closed angle becomes an open angle. As you can see here, we are doing an air tamponade, and the lens is stable, if the iris is proper, everything will be all right. So what am I trying to tell you basically is, we tend to do the glued IOL. This was a case referred to me from Bombay. This was a fellow eye. A very good friend of mine, Dr. Natarajan, sent this case. Ladies and gentlemen, if you have friends like this who send you such cases, trust me, you don't need enemies. Okay? Now you can see what I'm doing is I remove the silicone oil. This is the technique of photopuplasty, where you just pull that single pass out, remember the number 4, and pull on both ends, and that's game, set, and match. So once I have done that, I remove the oil, I've done the photopuplasty, I inject my graft inside. Look at my trocar AC maintainer. So this is pre-op, 3 months post-op, 6/18, fellow eye, one-eyed patient, no PL. We've done this in infant donors. See the pre-op, post-op at AC IOL explantation, vitrectomy, glued IOL. This was a one-eyed patient, only eye, failed PK. Look at the anterior segment OCT below that also. Another patient with scarred cornea, pre-op, post-op 1 month, 6/9. My wife came to me and said, listen, I got a nice case for you. You please fix this, come from Philippines. I said, are you joking? I can't see anything inside that eye. What am I going to fix? She said, no, you fix. If you fix, it's good. So I said, okay, let me try. Now, I can't see anything. I taken off the epithelium. I still don't see anything. I'm seeing some lens there. I used an endometer. I still don't see anything. So I said, now, I made my flaps. I've made my sclerotomy under the flaps. Now, since I'm not seeing anything, I said, let me go in and put an endometer inside the iris. The other is stuck to the iris. So I grab that, and I'm bringing it up anteriorly. made my scleral tunnel incision and explanted it out. So far so good, case not over, because now I have to do the glue IOL. So here you can see I'm taking the lens just like a non-foldable, because I'd already made a larger incision for explanting the iris claw IOL. If you are not seeing anything on that video, please understand, even I'm not seeing during the surgery, okay? So I've externalized both the haptics. Even with the endometer on, I'm still finding difficulty to see. Once my haptics are tucked, I know my lens is in place. Now my next step is I have to do the fourth row pupillasty, because I need to make that pupil smaller, as I explained to you. So I'm doing the fourth row pupillasty. I've done it on one side here. Now I decided to do more, and as I'm doing more, you see how the iris is cheese wiring. Now as I'm doing more, I'm trying to break the peripheral anterior synechiae also. I just could not complete it. So when I could not complete it, I said, I don't know what I'm going to do. So I said, let me leave that fourth row for some time. Let me take out this fibrotic tissue of the endothelium, desmase, and all that mess which is there, as you see. So you see, I'm taking it all off one by one. The problem with this fibrotic tissue is also stuck to the iris. So you have to be very careful when you are removing it, and obviously I'm not a great surgeon, so you can see I'm ripping off the iris more. So I take my vitrectomy probe to disengage that from the iris tissue. But as things stand, you will see slightly clarity is slightly better. So I'm now able to complete my single pass fourth row pupiloplasty. So here you see now I'm pulling that, continuing my fourth row pupiloplasty which I left in the middle. Now I pass the fourth rows inside, pull it. The bargain, if you notice, there's a large iodialysis also present. A technique which we started for this is the trocar assisted iodialysis. Here I'm doing some more single pass fourth row pupillasty, and I tell people, if you know the two techniques like fourth row pupillasty and the trocar assisted iodialysis, you'll be able to fix everything else. Here you can see the key issue is the Purkinje image, P1. That's bang centered. Here you can see a trocar fixed right opposite the iodialysis. Now you take a double arm suture. This is a modification of Michael Snyder's hangback technique. The advantage with the trocar is you don't go through the corneal lamella at all. Now I take my PDEC graft, prepare it just like I explained to you just now. Remember, this is a type 1 bubble. It doesn't go to the periphery. If it goes to the periphery, that's type 2. That means you'll get a DMEC graft. Inject inside the graft through any technique you want. Once you have done that, unroll it. The question was, patient is coming all the way from Philippines, can't come back. So I have to see how the patient behaves now. Pre-op, post-op, 2 weeks, you can see how the patient is 6-12, where the explantation was done of the iris claw, glued IOL, fourth row pupillasty with PDEC. The final thing I'll show you this last one. Patient with infective keratitis, and this is come out already in the cornea journal. They did a therapeutic PK. Invariably, these will fail. So you take out the epithelium after 4 months, when the graft is now okay, the infection is controlled, doing a phaco, putting an IOL inside. Now remember, please remember, you need to do the fourth row pupillasty, because what I'm going to do is I'm going to break those peripheral synechiae. I also tend to do a pinhole pupillasty in these cases, because any astigmatism will get neutralized. So how much of astigmatism you want to correct, you can correct as much astigmatism as you want. The key is always check, when you're doing in the refractive case, the higher order aberrations. Once I have done this, you can see my pupil becoming bang on track there. Take the vitrectomy probe and using it, check whether the pupil is bang centered. Now I've got air continuously inflowing inside the eye. I'm taking off my endothelium desmase. Now I create my bubble just like previously shown to you all. And we always use young donors, as I told you. We don't go above 35 to 40 years. Inject the graft. Now let's see how this patient behaved post-operatively. Once my graft is unrolled, I just inject the air and I can fix it back, because the Duas layer helps me a lot. So you can see now pre-op, post-op day 1, how the patient looks, pre-op, post-op, post-PDEC, and you can see here 1 day post-op how the patient is looking, and then I'll show you the final pictures 3 months post-op, vision improved to 6/9, basically from darkness to light. Thank you very much, ladies and gentlemen.
Thanks everybody. Thanks Amar for your participation. Unfortunately, there is no time for panel discussion. We are way past our scheduled time. Thank you all for coming and participating in this session.